Well, I'm going to be very egocentric on this. The highlight of the meeting for me was the Lifetime Achievement Award that I was given. And it was obviously very nice for me, but it was also very nice for the colleagues that I've worked with over a number of decades. Not only the clinicians, but the physicists, particularly because I've had a lot of my career spent in developing radiotherapy techniques for prostate cancer. But the pathologists, the clinical nurse specialists, the clinical trial teams and coordinators, particularly at the Institute of Cancer Research and the Medical Research Council, and all my research fellows, because as I said, research fellows actually do the work, and it's very nice for the team leader to take some of the credit. But that was, I'm going to stick at that. That was the highlight for me of the meeting. So that's very personal. There's two ways of two prongs to answering that. And I'm going to start off with the radiotherapy for metastatic disease. What to many people surprise has happened as part of the Medical Research Council Stampede study is that the patients who had metastatic disease presentation, when they were given radiotherapy to their primary tumor, if they had a relatively limited amount of metastatic disease, let us say less than 3 or less bone metastases, their survival outcome was improved. So not just their biochemical failure outcome, but their survival outcome was improved. And that is now standard of care. So that all patients with limited amounts of metastatic disease should have their prostate treated with local radiotherapy. I know there are some urologists who want to do prostatectomies, but there's actually no evidence that doing the surgery has the same benefit. So I think that's a very exciting and important result. The next study that is being done by the Stampede group is to treat oligometastatic disease. Now, that is disease where there are a small number of metastases, and you can define it as 3, 4, 5, 6 metastases, and there's some variability on how's that done. But this, again, will be a randomized trial. The oligometastatic disease will be treated, and it's going to be very interesting to see whether that actually improves long-term outcome as well. It's just slightly analogous to the PROMPTS trial, because that is treating the bigger areas of metastatic disease with radiotherapy and actually having some advantage for the patients, not a survival advantage on that occasion. So I think that's going to be very important. The other aspect to treating metastatic disease with radiotherapy is with the targeted isotope treatment, the prostate-specific membrane antigen lutetium targeted therapy, where PSMA positive cancers, and most prostate cancers are PSMA positive, they take up the antibody attached to the isotope. And so disease at all sites within the body are treated. So I think that is a very promising avenue of research in the future. And there are negotiations underway at the moment to see whether or not that can be included in the Medical Research Council Stampede trial. So I think there are really very exciting prospects for expanding the role of radiotherapy. And that would be in castration-sensitive disease. There's also work to continue on treating castration-resistant oligometastatic disease. So to see whether or not trying to focus on sites of particular problems patients is going to produce a longer-term benefit. There's preliminary evidence that actually is quite likely to be successful. And the good thing is, particularly when you use the more technically advanced stereotactic body radiotherapy techniques, is that you don't cause really any significant side effects for the patients. It's actually, for the patients, is a very simple and quick treatment, unlike chemotherapy particularly, but also the longer-term effects of hormone therapy can be really quite significant in some patients. It may just be another new weapon in the armamentarium, which I think is very positive. So that's metastatic disease. In localized disease, there has been a transformation in treatment over the last 20 years. And we've moved through a succession of technological innovations, from the old standard radiotherapy to shaped beams using conformal radiotherapy, to super shaped beams using what we call intensity modulated radiotherapy, where we can pretty well produce whatever shape of high dose that we want. And in parallel with that, there have been image guidance techniques introduced, fiducial marker placements, but in many ways, most excitingly now is the beginnings of the serious research using the MR guided linear accelerators. Now that allows you to not only see the cancer while you're treating it and adapt the treatment very, very precisely to exactly where it is. It means actually you can change the treatment actually while you're giving it, potentially, because along with these technological advances in engineering and treatment delivery, the huge increase in computer speeds allowing us to do what I can call real-time treatment planning. So actually, instead of taking 2 hours to plan a patient using the old planning computers, this can now be done in a few seconds. So it's like many other aspects of life that the computer speeds have just revolutionized what one can do. And the challenge now is to harness those increased technological computer possibilities with imaging, because if you want to treat a cancer with radiotherapy, the best thing to do is to be able to see it. If you can't see it, it's a bit like shooting in the dark. So imaging is terribly important. And then the technology actually to deliver the very, very precise radiotherapy. Now, all of that is actually coming together. And that gives us a very, very exciting era over the next 10 years, particularly because we've learned from the trials that we've done that we can start to reduce the number of treatments, radiotherapy treatments or fractions that we give. So this used to be up to about 40 treatments per patient to give a radical curative dose. Because of the CHIP trial with which I was involved, it came down to 20 treatments. There are studies now using, already reported, using 7 treatments, which look to be successful. Big trial, the PACE trial, coming down to 5 treatments, and that's going to report within the next 2 years. So that means you can use all of this fancy new technology. You don't give 40 treatments, you give 5 treatments. That is hugely better for patients. And it's actually hugely helpful to the use of health resources. And when we came down from it was 37 treatments to 20, we reckoned in the UK that we were saving about 30 million a year. So not only are you saving money, but you are actually giving more access to other cancers because the radiotherapy machines weren't being so fully utilized for prostate cancer. And in the UK, about 28% of the radiotherapy machine usage was for prostate cancer. Breast cancer a bit higher, but those two were considerably over 60% of the total use of radiotherapy machines. So bringing the number of fractions down in both prostate, and the same thing's happening in breast cancer, is really very important. And if you're health planning, you need to be thinking ahead of actually how to guide the purchase and use of such resources in the future. Now, the current trials that are being explored are in infancy, but trying to bring the treatments down from 5 fractions to 3 or 2 fractions. So that is potentially really a very major step. The other bit of imaging and technology that I think is very important is that for the first time using MR, you can actually see the cancer within the prostate gland. So in the past, you treated the whole prostate gland to the same dose, and that's what everybody did. And in fact, that's still what virtually everybody does now. Now, on an MRI scan, you can see the cancer within the prostate, and it's usually not in all of the prostate. It may only be in a very 10% of it. And you can then actually concentrate more dose on that area. And our preliminary results suggest that the recurrence rates really do come down to a very, very low level. So, we were down to about 4% in the presentation that my colleague Julia Murray gave, compared to about 10% without such fine tuning of the image guidance. Now, that was so successful that we actually decided that we couldn't do the next step and put the dose up any higher because we couldn't do any better. That may change with more follow-up, but at the moment, we think that actually we've reached an ideal dose and we don't need to go any further. What we do want to do is see if we can't actually take those number of fractions down using those very detailed image guidance techniques from 20, which is what we were reporting in ESTRO this year, down to 5 and maybe even lower than 5. So there's a very exciting decade ahead for radiotherapy.